Some studies have shown that the development of diabetes after renal transplantation increases the risk of infection as well as the mortality rate. To guide us about this, we have our next speaker with us, Dr. Bismay Kumar. Nothing much to say about him. And as a chairperson, we have Dr. Tonima Das Bhattacharya, a very enthusiastic and renowned nephrologist attached to Narayana Hospital, Howrah, and Dr. Shoikot Ghosh, consultant physician and pain management specialist. So please welcome our speaker.
Good morning. I have nothing to introduce about Bisway. He is a renowned consultant nephrologist in not only in Howrah but the eastern part of the India. And today's session he is going to enlighten us on the NODATs and on the different aspects. I think we can be enlightened by him. So what are the drugs causing, or what are the consequences, and what are the modifiable or non-modifiable risk factors, and how we can modify. I think we can all get enlightened about all the aspects of the NODATs. Thank you. And over to Bismay Kumar, please.
Thank you very much, and a very good morning to everyone. After that marvelous presentation with Somnath, it just reminds me of how today is a very special day. Today is Mahalaya, and today is also India-Pakistan match. So it just reminds me how Rohit Sharma bats as an opening batsman. So he has opened the innings very fast. I don't have such beautiful diagrams and sketches like him. My presentation is more of a review of literature. So you may not have such beautiful pictures, but you will have a lot of literature and evidences. So it's a totally different angle I'm taking you guys. Today I'm going to speak to you about new onset diabetes after transplantation. My focus here is on renal transplantation, but all the rules apply almost the same for all solid organ transplant. But recently the things have changed, and possibly we are having a new terminology, which is post-transplant diabetes mellitus. Now I'll explain and remove this confusion of terminologies. Now what is PTDM? PTDM is basically presence of diabetes after transplantation, and what I had the topic today is NODAT. Both is almost the same, but there is a little difference. In NODAT, this terminology came in 2003 when a group of nephrologists came with the idea that yes, we are seeing diabetes after transplant. There are many things. Probably these are the immunosuppression which is causing some kind of glucose metabolism disorders. That's why it is a new onset. But later on, people started realizing there are a subgroup of patients who had transplant prior to diabetes, prior to transplantation. So we didn't include them. So then the new terminology came as presence of diabetes after transplant, or PTDM. So now on, I'll refer my topic as PTDM. Then there is a third terminology, which is transient post-transplant hyperglycemia. What is transient? The word itself explains it. It's a transient, small phenomena which gets corrected. Sometimes it may be because of stress, infection, high immunosuppression, but these factors are transient. So PTDM. Now what's the epidemiology? NODAT or PTDM, the prevalence is around 7% to 46%. There's no single study which can tell you that one particular frame of percent. It is varying from center to center. Previously, when we were starting our transplant programs, 1/3 of non-diabetic kidney transplant recipients developed pre-diabetes, developed PTDM, post-transplant diabetes mellitus, by 6 months post-transplantation. That was the era when we were solely dependent on steroid therapy for post-transplant care. Subsequent data, then this is a big registry for data, the OPTNS SRTR, that is the Organ Procurement and Transplant Network Scientific Registry, which showed that slowly this incident has come down from 10% in 2007 to 4% in 2016. And 5-year incidence of post-transplant diabetes mellitus has approximately decreased from 16% to 10% from 2007 to 2012. However, whatever study you pick up, long-term studies, 2 to 5 years incident rate is around 18 to 33%. But if you see this percentage, really it's high. Now there are some risk factors. Risk factors like any other disease, in diabetes, in PTDM also, there is non-modifiable, there is potential modifiable, there is something which you cannot do, that is non-modifiable and modifiable risk factor. Non-modifiable risk factor, you cannot change your genes, you cannot change your age, you cannot change your gender, family, HLA matching, mismatching, acute rejection history, disease donors, male donors, polycystic kidney, these are genetic. Then there are potential modifiable factors which probably you can treat and control this diabetes happening after transplant, like HCV, CMV infection, post-transplant, impaired fasting glucose and impaired glucose tolerance, proteinuria and hypomagnesemia, which has some doubtful role but has been referred in some literatures. Then there are modifiable factors, individual immunosuppression, example tacrolimus, cyclosporine, steroids, mTOR inhibitors. Now, people who don't know about these drugs, these are the drugs which we are using as a immunosuppressive agents to maintain the graft function post-transplantation. And of course, obesity is the other component of the metabolic syndrome, which is definitely modifiable. We'll start with glucocorticoids. Now, glucocorticoids, we all know during transplant we have to use a very higher dose. Now this dose starts tapering. So when in the initial parts, when you have a higher dose of glucocorticoids, it tend to develop PTDM. The risk of developing PTDM is as high as 5% per 0.01 milligram kg per day increase in the prednisolone dose. Now, you have to rational the dose titration and reduce when possible to prevent an acute rejection. You should not let the rejection happen, as well as you have to reduce the dose of immunosuppression. Then comes the CNI. All of you know that there are two drugs, tacrolimus and cyclosporine. These are called as calcineurin inhibitors. Now both cyclosporine and tacrolimus increases the risk of PTDM. Tacrolimus is more diabetogenic than cyclosporine. Levels, especially you know that we do TAC levels, tacrolimus level, to maintain the dose of, because if it is a drug which has to be maintained in a very narrow therapeutic margin. So TAC levels more than 15 nanogram per ml were significantly higher associated with development of glucose intolerance and PTDM at 1 year. But the good point, the light of the day is it's a reversible disorder. So you may not always change the drug, you can alter the dose, giving the balance of maintaining the graft function. Then comes the mTOR inhibitors. mTOR inhibitors is another group of immunosuppression. Example is sirolimus and everolimus, but both are diabetogenic. The conversion, some people think that can we convert from CNI to sirolimus? No, it can significantly worsen rather than improving in the insulin resistance. Now, PTDM, similar, it's a similar between sirolimus and tacrolimus. So we don't have any advantage of changing to mTOR inhibitor. What about other agent? Yes, we have little relief on those sides. Azathioprine, MMF, belatacept, they do not have independent diabetogenic effect. So there are good options. Azathioprine and MMF should also be associated with decrease in the incidence of post-transplant diabetes mellitus. Now, there are some patients who have preoperative impaired glucose tolerance, or during the transplant period, especially during admissions, they have high sugar level. What about them? They have a high risk for developing of PTDM. The risk of PTDM is highest among patients who require insulin. Although the incidence and the relevance of perioperative hyperglycemia depends upon center to center. Center to center, which I mean is everybody don't follow the same level of immunosuppression. Some depends upon the level of matching, some whether the transplant program, how they are doing it. So the immunosuppression is the determinant of how your sugars are going to behave in the next period for that patient. Obesity, we all know, several studies have found that BMI more than 30 have increased risk of PTDM. Then comes the infection. Two infection, which is most important, SCV and CMV. SCV, to start with, it correlates both with pre-transplant and post-transplant diabetes. There was a meta-analysis of 10 studies involving 2,502 patients. And what they found that patients who were infected have 4 times higher incidence of having post-transplant diabetes mellitus. Now, what is the mechanism? The mechanism is basically the cytokine release, and there is an injury to beta cells. This SCV-induced islet beta cell dysfunction dysfunction causes insulin resistance, and due to liver dysfunction altogether causes hyperglycemia. HCV infection potentially is a modifiable risk factor because you can treat it, you can manage it. Then comes the CMV infection. The mechanism is also same. It also increases the incidence of post-transplant diabetes mellitus. Hypomagnesemia, not well studied, not well matched, but yes, low magnesium level in some studies has been shown to be associated with insulin resistance and diabetes in non-transplant patients. However, when we want to compare the level of magnesium with the level of glucose, there are conflicting results. So I will not be able to convincingly tell about this factor. Then there are non-modifiable risk factors. I have just mentioned age, more than 40 to 45 years, African American race, Hispanic ethnicity, history of gestational diabetes or first degree family history with type 2 DM, increased HLA mismatch, because once the mismatch is there, you tend to use more and more immunosuppressant. Male and deceased donor allograft, polycystic kidney may confer an increased risk of PTDM, although it has been not consistently observed in all the patients having ADPKD. Then comes the genetic factors. Now, diagnosis. This is the most important part. How frequently are you going to diagnose this patient for PTDM? First frequency is weekly for 4 weeks, and then 3 months, 6 months, 1 year, and then you have to check every yearly. The best thing is to check for fasting and postprandial. HbA1c is a good option, but only after 3 months. 3 months and then every 3 months, HbA1c is a good option to check for diabetes. So you have to check diabetes not all the time. The time when the patient is stable, the time when the patient is not in the feature of acute rejection, the time when the patient is having no infection. So you have to check PTDM in those, we have to check for PTDM during that time. So we avoid labeling any patient having PTDM in the first 45 days or 1.5 years. You know why? Because the first part of the transplant is full of immunosuppression and there are infection and patient is going through a rough course. So once those things get settled down, diabetes wanes off. So we cannot cause them having PTDM. So diagnosis, you all know, these are known to everybody. And next, this is the same slide. We are explaining as the days progresses how you are going to go about with the diagnosis of PTDM, and then first part will be insulin, and then you can convert to OHA. Now, talking about the management of hypoglycemia in the first 6 weeks after transplant. Now let's talk about the first week immediately post-transplant. You have two categories of patient. One who are critically ill, more than sugars 180, they should be treated with insulin therapy with standard intravenous insulin infusion protocol, target the blood glucose between 140 to 180. Non-critically ill patient, what are the options? Transient insulin infusion, 2 subcutaneous insulin regimen, target the fasting to less than 140 and random to 180. But use of basal insulin protects from PTDM, and intensive glycemic control does not have any benefits. So all those things has to be kept in mind. Then we are progressing from 1 week to 6 weeks. What next? What are going to do? The patient is getting discharged. Then educate the patient. Educate the patient on self-monitoring of blood glucose at home. Now, everybody knows that checking the sugars early in the morning is the protocol. But the patients who are on immunosuppression taking steroid dose, especially in the morning, for those patients, the fasting is most important pre-lunch. There the sugar rises. So teach them to have twice per day, usually the fasting, and then slowly reduce the frequency of checking the sugar level. Insulin, when it is more than 20 units per day, continue insulin therapy, but options for insulin therapy is NPH insulin, which is preferred at single dose, initially 5 to 10 units, and adjust based upon the afternoon glucose values, as I told you. Alternate options include insulin glargine, which is administered easy to go, only once a day at the night to control the morning fasting levels. Then there are other options like pre-meal short-acting insulin aspartate or insulin lispro, based upon the pre-meal glucose level and anticipate the carbohydrate ingestion, what time he has taken the major meal, and you have to design your insulin as per the meal requirement of the patient. Once your requirement of your insulin comes to less than 20 units per day, now that is not going to come down itself. You have to also reduce the immunosuppression levels. Then that is going to happen. Then you can have the transition to go for oral hypoglycemic agents. So once the insulin level is less than 20 units per day, then probably you can come down to OHA. Now what are the options in OHA? Now in OHA, meglinetide, that is repaglinide, DPP-4 inhibitors, and sulfonyl ureas are the first 3 options which comes in mind when you are transiting this patient from insulin to OHA. Now, the important part is hyperglycemia improves with the dose reduction of the immunosuppression. So you may not always go on the other side, not go always increasing the insulin level, increasing the OHA. You can also look to this side, reducing the immunosuppression. Then there are other things like every other diabetic management, lifestyle modification, diet modification, weight reduction, exercise, pharmacological therapy, first with OHA, and then probably if it is not controlled, then go to insulin therapy. Now coming to OHA, what are the options we have? Metformin. Again, metformin is not, we tend not to use. It was the classical thinking, but probably in the few days, newer studies are coming, which is actually promoting insulin, but not below the GFR of 45. We do not use routinely GLP-1 analogs, alpha glycosidase inhibitor, and SGLT2 inhibitor as the first line oral agent. We can use at second and third. These agents may be considered when you have additional requirement of therapy and who do not tolerate the first line of therapy. What is the emerging data suggesting? Emerging data are suggesting that SGLT2 inhibitors is associated with many benefits beyond the glucose that we are learning day by day in using SGLT2 inhibitor. Thiazolidinediones generally not used in transplant patients for the fear of edema. Then coming to sulfonylurea. Sulfonylurea, gliclazide, glipizide, glimepiride. Preferred to glimepiride, but all these drugs is preferred when you have GFR more than, you can use glimepiride if you have GFR more than 50, but below 50 you have glipizide, glimepiride. But you have to be very careful with hypoglycemic events when you're using this drug. Begin with glipizide 2.5 to 5 milligram orally daily and advance to 10 milligram twice a daily, and maintain the glycemic control to 7%. Less than 5% of glipizide is renally excreted and does not change the cyclosporin levels, and that is the beauty of this drug. Magnetinide, yes, such as repaglinide, has been shown to be effective in PDDM patients. One 6-month study showed that HbA1c level reduced from 7.6 to 5.8% in 14 of 23 patients with PDDM. Remainder required insulin. Now coming to DPP-4 inhibitors. The most important part is safe and effective. That is how we feel safe, because across the GFR we are using this DPP-4 inhibitor. Carmelina, Carolina trial, all we know linagliptin is clearly have benefit role, and because it has an intrahepatic circulation excretion, not renal. And the major interaction with immunosuppression is also not there when you're using this drug, except sitagliptin, which can cause increase in the level of cyclosporin and cause prolonged QT intervals. Talking about GLP-1 receptor antagonist, not used as a routine first line for limited evidence in PTDM, but yes, liraglutide is slowly gaining evidence. In one study, it has shown to reduce the HbA1c levels. Then alpha glycosidase inhibitors. First line drug, no. Second line drug, no. Yes. After that, you may think about it if you run out of option. Why? Because it has more GI side effects. And already when you are having patient who is taking MMF or mycophenolate mofetil, another immunosuppression called antimetabolite, you may have acceleration in GI side effect. Thiazolidinediones, I've just explained, usually it is not used among transplant patients because of fear of worsening of edema. Rosiglitazone is off market and it is never used in these patients. Now, I'll give some slides to SGLT2 inhibitors. Now, routine use of this drug in kidney transplant patient is not recommended at this time, but slowly the evidence is gaining. Because why we are not using this drug? Because you see, kidney is an organ which is placed artificially. So you don't have the ureteral mechanism where it can prevent its reflux. So there is a high chance of urinary tract infection. Second, they are already on immunosuppression. So there is a double chance of having urinary tract infection. Fear of UTI is a reason why we are escaping SGLT2 inhibitor as a first line agent. Minimal drug, but it has minimal drug interaction except rapamycin. And there are small studies having some beneficial role favoring EMPHA and CANA versus placebo. But many more studies are coming up which is suggesting benefits beyond sugar control, and there we are interested to use it because it has benefits beyond sugar control. In one study, large patients, 2083 kidney transplant patient experienced lower risk of death-centered graft failure. What is death-centered graft failure? Is graft failure which is devoid not because of the patient dying, because of patients from other reasons, and doubling of creatinine. These things had advantage when we are using SGLT2 inhibitor. But another one important point is when you're using them, in 16% of these patients, there's a transient rise in the creatinine and reduction in the GFR by 10%. And that is a very small window period when we get scared that creatinine is going up and we tend to do biopsies and all that. But this is reversible. This patient settles down. So that part we have to be little careful when you're using SGLT2 inhibitors. Insulin, when the sugars are more than 200, when oral agents are not effective, definitely you go for insulin. And most important part, you have to think about your immunosuppression levels. You have to improve the sugar tolerance. You have to consider either reducing or maybe in sometimes altering immunosuppressant agent. But you have to weigh this against rejection. So you may not reduce the immunosuppression to cause rejection. That may be not recommended for this patient. Steroids, decrease as soon as possible, but complete steroid withdrawal is not recommended. A reduction to 5 milligram per day at 1 year has been associated with decrease in glucose tolerance from 55 to 34%. A complete sugar withdrawal can reduce the incidence of PTDM, but significant patients can suffer rejections in this patient. So in one study, there was actually no improvement in insulin sensitivity without steroid therapy. So again, it is saying that you may not totally withdraw steroids in this transplant patients. Then some studies are also advocated using dividing the dose of steroids into day and night regimen. But then these studies are very small to actually conclusively tell that you can do it. Tacrolimus, CNI, tacrolimus is associated with higher rates of PTDM when especially we are using more than 15, but do not switch from tacro to cyclo because that doesn't have any effect. Reversible phenomena is with tacrolimus. Once you reduce the tacrolimus, then probably you can get the sugar control better. So improving the graft survival and tacrolimus therapy despite increased rate of PTDM with tacrolimus has been seen. Major data, USRDS, United States Renal Data System, has shown that if you use, when the era was there where the market shares of tacrolimus and cyclos, now we are using more tacrolimus, but a time was there when cyclo and tacro was almost equal in the market. Then also it has shown that tacrolimus doesn't have an added effect, that it doesn't reduce more than cyclosporine the graft survival. So switching to cyclosporine only you can consider when you have other side effects of tacrolimus. Otherwise, it's better to just taper the dose of tacrolimus based on your TAC level. Conversion of mTOR inhibitor, again, it's not recommended. Some studies have shown to use belatacept. It's a newer immunosuppression, but again, this conversion is not for sugar control, they are for other reason. Monitoring, I've just spoken to you, 3 monthly HbA1c, reasonable target, HbA1c 7, in elderly morbid patient around 8. KDOGI recommends 7 to 7.5. What is going to happen to the patient? Patient survival. One study, 1 year survival was 83% and 98% in those patients without PTDM. So definitely there was less survival for PTDM patients. But this was in an era when we are using high immunosuppression. Subsequent data has shown that there is no association of new PTDM with death or with functional graft. 2 minutes. Okay, so coming to the end, what is the consequences? What are going to happen with PTDM? We have increased cardiovascular mortality, we have poor long-term survival, and PTDM on cardiovascular and overall mortality is also more. PTDM complication is just like diabetic complication. You have sepsis, infection, pneumonia, and micro and macrovascular complication. But the difference is, a sugar patient versus a PTDM patient tend to worsen very fast. They tend to deteriorate very fast. And what about the kidney? What is going to happen to the kidney? This is a conflicting result. Most of the studies have shown that PTDM is causing graft survival, reducing the graft survival, but they are not eliminating rejections. So it is important to decrease the diabetogenic immunosuppression therapy, but not at the cost of rejection of this patient. So to conclude, my friends, there is studies, though the duration of these studies have limited days, but they are large studies. What they say is acute rejection is most significantly potential modifiable factor. Means you can modify treatment for acute rejection and increase the allograft survival. But importance is maintaining the adequate immunosuppression, even at the expense of your sugars. So even if you have diabetogenic potential for immunosuppression, don't go down too much on immunosuppression so that you may land up in rejection. This is a beautiful article. I'll recommend you to read this. This is a trade-off of acute rejection versus new onset diabetes. So basically, my friends, it's a balance of immunosuppression and sugar which you have to maintain. And this balance is taught to us from all the spokes of life. Today is Mahalaya and everybody remember mother. And I remember my mother, and this is her picture. This is on her last birthday. I lost her 6 months ago. And she was sitting in this chair last year, encouraging me, getting people from the other hall to listen to my talk. So all the teachings, all the balance in life is actually taught by our parents. So we love you. And many of her friends are also here. So thank you very much. And any question, over to you, my chair.
Very well spoken, Dr. Bismay. And I had met your mother when she was very sick, and we all really miss her. I heard that she was a very good lady and very pragmatic lady. Okay, coming to the topic of NODAT and PTDM, I think Bismay has already explained all the differences, that why the terminology was changed. So I open up to the house for any queries if you have. Then I have one of mine.
Any question from anyone? Ma'am,
I'll
this is
request yours.
for you.
Bismay, the role of vitamin D monitoring in these post-transplant patients, will you enlighten us regarding the role of vitamin D monitoring?
Vitamin D3 monitoring is important for this patient post-transplant, but when I went through literature, they have not advocated any studies which is directly related to PTDM incidence and their occurrence and control with respect to vitamin D3. But probably you can tell it better. I don't have much information.
No, you are absolutely right. Because in case of insulin resistance, we think of vitamin D deficiency as well as hypomagnesemia, and that is what is you touched upon magnesium. You just I think purposely omitted the vitamin D part because there are no specific studies on PTDM. And another thing is that regarding PTDM, is there any difference between the microvascular and the macrovascular complications? Means a diabetic nephropathy having a renal transplant, his future, and a PTDM having his future regarding the micro and macrovascular complications.
One study has shown 16 to 18% chances of developing ocular and neurological microvascular complication post-transplant at the end of 5 years. But we don't have any study beyond that. And the incidence of having diabetic nephropathy post-transplant, this is also not very clear in all the literatures because they are not evidenced with biopsies. They are evidenced with clinical situations. So probably there is a chance 18 to 16 years, but because these patients deteriorates very fast, we don't have any proper track record is what is happening for further macro and macrovascular complication of these patients.
Absolutely true. Another thing is regarding metformin, because these patients, after so many days of vintage of dialysis and transplant, they usually want to avoid pricks. So what I have found that the patients, they settle down with metformin once their GFR is good, means once they are on stable immunosuppression. And you rightly pointed out about the GI side effects, especially with MMF and metformin together. And what's your take on SGLT2? Means we keep on itching on starting SGLT2 because of the positive effects of SGLT2 in the even non-diabetic CKD population. So what's your take?
See, SGLT2 inhibitors, in initial days, it was not very taken well as a practice pattern as a first and second line drug, but they took over as a third line agent. The why we don't have any data on how many patients are actually having mycotic and urinary tract infection, it is an anticipation because kidney when it is transplanted do not have this protective reflux mechanism specifically at the utero-vesical junction. They don't have the valve mechanism proper there. So there is a high chance, this is anticipation and theoretical hypothesis, that they can land up urinary tract infection because they are already immunosuppressed. and they don't have, and once you have pyelonephritis infection, it's a very dreaded complication. You may even land up in nephrectomy for these patients. So that is why it is not taken up, but there are evidence in recently small studies, 44, 11, they are supporting use of EMPHA and canagliflozin when they are compared with placebos.
I do not have the question, but exactly you have pointed out the point regarding which I am also concerned as an endocrinologist. So we all know that SGLT2 has got many benefits beyond the glycemic control, and you
True.
also discussed that in some of the studies, post-transplant diabetes mellitus patients also, it has shown some benefit. The real concern is the urinary tract infection. Though the study says the average incidence is about 10%, but in real world practice or real world studies, the incidence is higher, about 20-30%, maybe more. And most of fortunately, most of the urinary tract infection is of lower urinary tract infections. But I have seen asymptomatic patients, when I put the patient on SGLT2 inhibitor, patient developed urosepsis, upper urinary tract infections, pyelonephritis. So that could be a real concern in post-transplant diabetes patients. So if the patient develops urosepsis or upper urinary tract infections or pyelonephritis, so that could raise medical legal issues. So that is the point.
Moreover, their immunity is reduced because of this immunosuppression. So even your highest doses of antibiotic fail to control this infection, and they become resistant. So that is why we don't want to go in that situation. So we keep this drug as second or third line. Probably the safe line is using a DPP4 inhibitors or going for epiclenide or using sulfonylureas.
Okay, a very nice, very elaborate speech as well, I mean, as usual. So thanks for that. But just one comment that what is the relationship of renal neoglucogenesis and GLP-1 in case of post-transplant?
Renal glucogenesis and
renal neoglucogenesis and GLP-1 receptor agonist.
GLP-1 renal glucose. I don't have an idea about this. If Tanima can say something.
No, I didn't get your question. What is the relation between
Renal neoglucogenesis? I mean, actually, renal neoglucogenesis is very minimal. It's not that great.
It's minimal.
As in liver, it's not that.
Yeah,
much.
actually means as far as I can state is that we use glucocorticoids, and these glucocorticoids result in more of hepatic neoglucogenesis rather than the renal gluconeogenesis, because this graft kidney is actually means there is no nerve supply. It's absolutely cut out. There is only the arterial anastomosis. So renal neoglucogenesis is probably much less important in this post-renal transplant
He has
setting.
asked about GLP-1
I know.
relation to.
He talked about the GLP-1 receptor agonist, and GLP-1 receptor agonist, we have not found several studies because this renal neoglucogenesis part is less. And but more of what he was saying is the DPP4. We are using linagliptins, and we are using metformins also.
Liraglutide has found space in one study where it has shown that HbA1c reduction, and they has been used in PTDM patient. There are some literatures liraglutide being used in PTDM patients.
Okay, thank you.
Sir, I have a small question. That you have correctly depicted that there is two groups who have the diabetes prior transplant and who develop the diabetes after transplant. So I want to know that what would be your difference in the approach in choosing the immunosuppressant and also choosing the OHs except the insulin. So in these two group of people, so who has the diabetes or DKD as the cause of the renal transplant, or who had not diabetes prior and who just developed as a NODAT?
This is a very good question, because once the patient comes to you for transplant, you are going to see the pre-morbid factors. And diabetes 1, there's another morbid factor, which is what is the level of matching of this patient, what relation, what is the HLA match. If you're using lower level of immunosuppression, you tend to use lower level of immunosuppression. Previously, cyclosporine was preferred as a CNI option over tacrolimus. But as I showed in the studies, that there is not much difference in the outcome if you are using tacro versus cyclo. So tacro is still the drug if you are using for pre-transplant diabetes patient, that is for the CNI. Steroid, we have to taper as early as possible and to reduce the dose as early as possible, keeping in mind maintaining the patients in a proper tolerance. We do not want rejection. Third, some patients can be switched to mTOR inhibitors, especially everolimus at 6 months. There are some studies, but again, that is not very convincing. So, and third option is to continue with MMF or azathioprine. This is the immunosuppression we are going. Regarding the drugs which you asked, one is when your requirement of sugars are high, you are going with insulin. But when your sugar requirements is insulin requirement less than 20, you convert to either DPP-4 inhibitors, or you consider sulfonylurea, or you consider ripaglinate as the first line agent. Second line agents are SGLT2 inhibitors, then other drugs comes in. So this is how you're going to put your armamentarium of sugar medicines, and your immunosuppression will still remain the same. CNI, go with tacrolimus, but reduce the dose, maintain your TAC levels within normal. Second, reduce your steroid whenever possible. And third, continue with MMF. So that has not changed much. Immunosuppression is given in two phases. One is induction, where you use higher doses of steroid. Second is maintenance. So induction therapy, we all don't compromise because we are all scared of hyperacute rejection. But maintenance, when you have attained a stable graft function, creatine has come down, then probably you start reducing your levels of steroids.
Thank you.
Thank you, Speaker. Thank you,
Thank you.
Chairperson. So, we have a token of appreciation for you. I would like to request the Chairperson to please felicitate our Speaker. Thank you, sir. Thank you, ma'am. I would like to request Dr. G.P. Vettacharya on behalf of HDS. Sir, ma'am, please be there. Chairperson, sir, ma'am. It's time to felicitate our chairperson. I would like to request Dr. G.P. Vettacharya to please felicitate our chairperson.